So with that, I'd like to get started with our speaker panel. The first team that we have is from University of California, San Francisco, and the community partners are from End Hep C SF and SF Hep B Free. So Dr. Tung Nguyen is a professor of medicine at University of California, where he provides primary care to diverse patient population. His research focuses on achieving health equity using community-based participatory research and also patient-centered outcome research. He has been involved in various interventions for culturally and linguistically tailored interventions to address cancer, tobacco control, hepatitis B and C screening, among other topics. And he will be joined by two of the community partners, Mr. Jordan Akerley, who serves as the strategic director of End Hep C SF, a multi-sector initiative working towards hepatitis C elimination in San Francisco, California, and Mr. Richard So, who's the executive director of SF Hep B Free Bay Area. He's passionate about fighting Hep B and liver cancer in Asian Pacific Islander communities, and he has worked in healthcare for over a decade with a focus in public health. So we're really delighted to have this team. So I'll turn it over to Dr. Tung Nguyen to get started with this first partnership.
Thank you, Dr. Das, and thank you, the organizer, for having us come and talk about our experience in San Francisco, California, in the US. Next slide, please. So just a bit of background. San Francisco is a large city in California with a very diverse population, approximately 38% non-Hispanic white, 35% Asian Americans, 15% Hispanic Latinx, and 5% Black Americans. And here's a graph showing the viral hepatitis rate in San Francisco in the red compared to the other counties in the state and the state of California in the blue. And since 2000, our prevalence rates have been higher than in the state, with a spike between 2004 to 2008. And we believe that this sharp spike may be a combination of demographics along with community-based activities like SF Hep B Free. You'll hear more about this work from Richard, but I wanted to show this paper from 2011 that shows some of the work that was done that may have led to the increase in screening and thus the diagnoses. Next slide, please. For hepatitis C, the prevalence in San Francisco has also been higher than in California. And again, this may be due to some combination of demographics and community-wide activities, including NHEP CSF, which started in 2016. This program was presented in a meeting last year, but Jordan will be telling you about one particular project. This photo was taken in front of City Hall for a press conference for both the Hep B and C efforts, and it includes members of the Board of Supervisors, the Director of the Department of Public Health, media personalities, community members, and researchers. And just wanted to show you that these efforts are a part of the city and county's various stakeholders. Next slide, please. Since this is about community engaged research, I just wanted to level set a little bit. This is sort of my rubric of what I think of when I think about community engaged research. There are basically three levels. Community engaged research, which is usually academic-led and community engaged. Community-based participatory research, which is academic and community co-led usually. And then community-led research, which is fairly new and which is led by the community and with the participation of the academics. Next slide, please. So I want to show you an example of community engaged research in hepatitis B control for Asian Americans. This is a few years back. It was a program grant funded by the NCI and NIH. It was for our team to conduct community engaged research in hepatitis B control for Asian Americans. We had 3 projects, each tailored to one Asian national origin. One was a quasi-experimental project to test immediate intervention for Vietnamese Americans. The second was an individual randomized controlled trial to test a lay health worker intervention for Hmong Americans. And the third was a group randomized controlled trial to test a church-based educational intervention among Korean Americans. The level of community engagement varied. For the media intervention, community members were on an advisory board and participated in focus groups. For the lay health worker intervention, they also led a community organization that recruited lay health workers. And of course, the lay health workers were community members. And for the church intervention, Korean church leaders were involved in development and implementation, but the academic team did the design, development, implementation, and measurement. Next slide, please. Here are the results. I'm going to go quite quickly to them. The quasi-experimental study for the media campaign for Vietnamese Americans showed that the campaign was actually not more effective, possibly because of activities in the control community. However, exposure to the media elements was associated with receipt of Hep B screening. For the randomized control trial of like health worker outreach among adults, the intervention did show a significant 3 to 4-fold increase in receipt of hepatitis B screening. And similarly, for the church-based intervention, the intervention led to a 5-fold increase in Hep B screening. So this, to me, shows that community-engaged research can have medium internal validity, as in the quasi-experimental study, and high internal validity, as in the 2 randomized control trials. However, these studies are not highly generalizable outside of the population that they were designed for, and even perhaps the geographic location where they were conducted. And more distressingly, both of the highly effective internally valid interventions have neither been replicated nor sustained. Next slide, please. Tell you about one other project. This is a project that was funded by the Patient-Centered Outcomes Research Institute, a group randomized study of the physicians to study the effect of a multilingual mobile application on Hep B and C screening in the primary care setting. Can you hit the next click, please? Keep going, please. Okay. So the providers in both arms receive a panel notification of those who have not been tested. And the intervention group of patients actually got an iPad application. Can you hit the next click, please? Basically, they all used the iPad application and brought a printout to their doctor. Next slide, please. And this is where the community and patient engagement occurred. They had a patient and community advisory board. They were all engaged in the development of the intervention, including the app, along with other community members. They helped us to troubleshoot issues around recruitment. We also engaged clinicians and clinic staff, which is another set of community members in the design of the project. Next slide, please. Just as a table 1 demographics, simply to show here mostly that the patients that were in this project was actually fairly reflective of the Asian American population as a whole. Next slide, please. And this is the outcome. We discuss, we measure several things, but the main thing to look at here is the testing done. This is electronic health record verified testing. And the intervention group had 7-fold odds of having actually the screening done for hepatitis B. And for those who did not have hepatitis C screening, 10-fold of getting hepatitis C screening. So a fairly effective intervention for this particular project. Just stay there for a second. So the bad news, though, that is when the research project was over, we were not able to sustain the intervention either within our own health system, and uptake outside was low. Next slide, please. I think we can all agree that community engaged research is better than traditional research in terms of identifying and addressing community needs using methods that are appropriate to communities. But there are other factors that go into choosing a particular research method, and there are trade-offs. This is a rubric of how we can think about the effectiveness of intervention research, starting with internal validity. Is the finding reliable based on the study design and implementation? Generalizability is the finding related to settings outside of the project, and sustainability, how the intervention will be continued when the project ends. So for example, in drug studies, internal validity has to be high. Generalizability is medium due to inclusion and exclusion criteria and research participation bias. And sustainability is high because our healthcare system pays if the drug is effective. For community-engaged research, since academic researchers design them, they tend to have medium to high internal validity and medium generalizability. But since we don't have payment system that actually pays for behavioral interventions, often, many of these are very hard to sustain, and I think I've shown that in the examples. CBPR has a better chance of sustainability because communities, public health, and other systems could be involved. However, because it's local community-specific nature, the generalizability can be limited. And community-led research, which is a brand new field, I think these issues are open. Next slide. Yeah, I'm really sorry. These are not the new slides that I sent, but we'll go with it. Fundamentally, the main barrier to sustainability of community-engaged research is structural. Who will pay for effective interventions? A true academic community partnership need to go beyond individual research projects. And due to all that we've learned, including some of the things I've shown, our cancer center created a San Francisco Cancer Initiative with the goal of reducing cancer disparities across San Francisco. This collaboration between our healthcare system, community groups, government, and academia. And this accounts for, addresses 5 cancers, which account for nearly half of that in San Francisco. And one of them is, of course, liver cancer. Next. And so our liver cancer task force within the SF Can initiative, our goal is to reduce liver cancer morbidity and mortality in San Francisco through Hep C elimination, Hep B elimination, increase liver cancer screening and access to liver cancer treatment. And actually related to what Dr. Das was talking about, we also have a few projects looking at the adequacy of screening and treatment for hepatitis B and hepatitis C within our healthcare system. With regard to the first 2 bullet points there, our partners in this work is UCSF and SFFB Free. Click, please. And you can end. I'm going to just turn it over to Jordan now to talk about UCSF. Thanks.
Thanks very much, Dr. Nguyen. So like has been said, UCSF is a community-based initiative. We work closely with our local health department, also with clinicians, frontline workers, policy advocates, community members, and researchers. Next slide, please. So to begin, I want to share a bit about UCSF's core values. The values that guide our work include that everyone deserves access to resources for HCV prevention, care, and curative treatment. And I really want to flag here, the focus of my few minutes here will be on that we really feel like it's imperative to draw on the wisdom of people who are impacted by HCV, including people who use drugs, people with experiences of houselessness, and other communities that are impacted by HCV-related disparities. We think that this community involvement is really critical to address disparities in our city. Next slide, please. So the program I'm going to focus on is our Community Navigator program. And this builds on our belief that our work is most effective when people with lived and living experience are meaningfully involved in this work. Our Navigator program is an example of this commitment. So the program itself trains people who supports and trains people with lived experience of HCV and or substance use to advocate for other community members. The way that we do this work is we fund several community-based organizations to host the program. The staff at those organizations recruit and support navigators who are embedded at those agencies. And then our initiative actually provides foundational training as well as ongoing community building events for those navigators. We've been doing this since 2018, and we've trained more than 120 people. We really feel like peer support has been an effective strategy to engage people who are most impacted by hepatitis C in San Francisco in prevention, care, and particularly to reach communities that may have experiences of mistrust and or are face barriers to accessing care either geographically based on systems or based on sort of disproportionate impacts of morbidity and mortality related to HCV. So through this program, we continue to build our understanding of community priorities, continues to shape the work that we do and the areas in which we focus. And I will note that in the past years, we've actually been expanding our partnerships to conduct needs assessments in conjunction with the health department, and navigators from our program have gone on to have employment through different sort of community-based participatory research projects and as staff and community-based organizations. Next slide, please. Just a snapshot of our accomplishments and sort of how the program works. One of our cohorts, which runs in a 6-month cycle, had featured 17 community navigators from 4 community-based organizations. In total, they provide 750 hours of service, more than 4,000 interactions with individuals in the community. The navigators themselves conducted 99 HCV antibody tests, distributed over 500 doses of Narcan, and reversed 16 overdoses. And many more folks in community were directed and supported to link with other testers at the community-based organizations that we partner with. Next slide, please. So in summary, NHEP-CSF has found that partnering with people with lived and living experience enhances our work and importantly recognizes the expertise of people who are most impacted by hepatitis C. Next slide, please. So here's my email address. I wanted to keep my remarks brief, but we continue to learn a great deal through our Navigator program, and I'd be happy to share detail about our experience and answer any questions either on via the chat or by email. And thanks to our partners for this opportunity to speak today.
Thank you, Jordan. And I'm going to ask Richard So to present on Hep B, please.
Thank you. I'll share screen now. So thank you first, Jordan, for your presentation. We actually work often together to amplify our work and hope to do more of that. So my name is Richard So. I'm the executive director of SF Hep B Free. And we are a small community-based grassroots nonprofit that really works on hepatitis B awareness and free screening in the San Francisco Bay Area. Just so a little bit of background, we actually began all the way back in 2007 for becoming the first of its kind, really grassroots-based collaboration between quite a few sectors of society, really focused on educating, screening, and linkage to care, bringing together a major player in the DPH at San Francisco, health systems. Almost every health system, hospital, and general clinic network was on board in our big overall meetings. And then community players. At the time, Asian Week was a large player. And so we had kind of our ear to the ground for folks in Chinatown and a lot of the Asian Pacific Islander organizations. You can see a little bit on your right. It was in collaboration with then Mayor Gavin Newsom and Assembly Member Fiona Ma. There were several bus ads. You can see the ad that was put on like bus terminals and shirts, and we even had a major ABC anchor, Alan Wang, who talked about it. So a major push then. Since then, it has continued, fluctuating depending really on funding, which brings me into the next slide, which is really the challenges and barriers for many of the researchers who are on this call. As you can imagine, for hepatitis B, the first initial challenge is the lack of awareness for both the public and some providers. Providers have gotten much more informed. We'd like to think that some of our work, but also just the work that many researchers and advocates have done. But for those of you who don't know, currently it's still mostly up to providers, individual providers, to really know who to screen. Now, fortunately, the CDC, as many of you know, came out and said everyone should be tested once. And here in California, we, as well with our other advocates, promoted a law that requires physicians to offer a free hepatitis B and hepatitis C test in the non-emergent setting. But also, as many of you may know, in order to pass that law, we had to write in that there was not going to be any punitive damages if physicians did not do that. So unfortunately, it's really still up to patients to request. Now, fortunately, anecdotally, as we've been out in the community, we see a little more testing. Folks actually have said, oh, I actually got Hep B tested. It got added to my test, which is great. On the other hand, some folks have said, oh, no, I still don't know about this, and I just saw my doctor. So we'll see. We, particularly for Hep B, have a lack of quality data in the city of San Francisco and across the counties. As many of you know, the difference between acute and chronic is not well kept. And every time for research and increased funding, people ask, well, what's the burden? What's the need? And unfortunately, public health institutions often don't have the resources to have that in a confident way. And so that's a major issue for us in the Hep B field here. We've quite frankly been told, so used to be during certain years, we had enough that we would fund a position that could really clean this data and have a more confident view of it, but that hasn't always been the case. Go into kind of the challenges that many residents face. That's linguistic and cultural. Many are Asian immigrants who don't feel confident or don't feel confident interacting with a provider, especially at the specialist level, who may not speak their home language. And then the stigma and misinformation that is common as an STD, even though many of you know the vertical transmission is the main way that Hep B is passed, you still have this deep stigma, especially across immigrants that come from countries where the disease is very stigmatized, preventing people from getting married or job opportunities. Moving on, we find it quite difficult to reach large numbers of our target population in efficient manners. And we know that this is just a issue that everyone deals with when you have a target population that's specific. So we end up going to lots of nonprofits that serve these communities to reach those audiences. We do reach folks through Chinese radio and TV, but we don't know how much behavior change that's going to actual cause, nor are we able to track that. And so that brings us to the next one. Creating behavior change is difficult. We've had some talks of mistrust in the healthcare system, especially in the Pacific Islander population, who often feel stubbed and left behind by all sorts of services. But we have faced that significantly, and we're trying to address that and build trust in the PI work that we do. There's a lack of urgency, unlike other diseases that are quite, I guess, I hate to say it like this, like showy or more immediately causing mortality. As many of you know, hepatitis B usually doesn't cause the liver cancer until later in life. And even then, there's no direct tie to Hep B that seems visible that people know about. So there is very much this sense of, I feel fine right now. Why should I do anything? And then finally, there's the lack of funding. This applies, we know, to so many issues, but particularly Hep B, because it's a mostly Asian American, African immigrant issue. There's just very little funding out there. For those of you who are in research or know about Hep B treatment drugs, the pipeline is getting smaller and smaller. The number of industry working on it is smaller and smaller, therefore making the funding from those industries smaller and smaller. And it makes it really hard for us to do more work. For those of you who don't know, all this work that we do, we have a staff of 2 full-time people with SFFP3. So on the other hand, I want to talk about best practices. It's really about understanding the audience in terms of who, where, and how. I think these are extremely critical and things that seem obvious, but really need to be done to be effective, especially when you have a small team. Like, who is your audience? And that's specific. If it is a Cantonese audience versus Mandarin audience, if it is a Pacific Islander audience, do your education folks look and sound like those people? Where are they meeting? This is a common thing. People go, let's just make put out a table and educate folks. But if you're not meeting them, if in their community zones, that's just not going to work. And we have some examples right here. The top picture is at a place called Self-Help for the Elderly that gathers a lot of old Asian elders for food and just social activity. The top right is in Chinatown during the Lunar New Year. The bottom left is at KTSF, the major Chinese TV station. And then the bottom right is employees at a Chinese dim sum restaurant. And so you can really see that we try to meet folks they're at, and that's critical. And you also want to do that by leveraging community stakeholders, which can make a huge difference with just a little bit of communication. What health systems work with this population? What elected officials have sway with this population and give you their their blessings? What nonprofits are working with them, and what ethnic Just wanted to show all sorts of the other work that we do. From the top left is a newspaper clipping in collaboration. You can see with two other partners, the Peninsula Healthcare District and the Asian Liver Center. Middle top is our work speaking to employees at a market in the city of Millbrae. Top right is at another dim sum restaurant. Middle is again a big city hall proclamation. And bottom right was our first foray into targeted digital PSA marketing, which, as many of you know, is like a major way people are getting information as opposed to mainstream media. So we tested it out, but that again is a kind of costly investment. Work in numbers. I'm not going to go through all of this, but you can see kind of what we attempt to do. We really try to get as many events done, whether that's talking to 10 people or 100. Our screening numbers are not that high because, again, we're not tied to a medical clinic, but we're proud of the numbers we do get. We try to do physician education. Direct education is when we feel like we've had a real educated conversation with a person one-to-one. So we're really proud of those numbers. These are literally like, I talked to you for 3 minutes to tell you about it, and they're listening. And then our indirect education accounts for radio, what we estimate for things like radio, TV, and newsprint. And so we're really proud this year. In the first 5 months, you can look at our numbers and they are larger than many of our other years' full years. So we continue to try to do great and expansive work. Just really quickly, these are some other couple examples. I want to particularly note the two middle pictures. The AB 789 was the law that it requires primary care providers to offer that Hep B and C. That was in 2023. And then we do a lot of proclamations, as well as educate physicians. That's your bottom left picture. And then look for grants. And so again, to address sustainability, it's really the need for grants and fundraising. So if there's a better way for all you researchers out there, how we can better collaborate with you all to find those resources and work closer with all of you researchers. For example, SF Hep B Free, because we're such a small shop, not tied to an academic medical center, we would love to work better to improve data with any researchers out there. I really just don't have the bandwidth to really look at that up. So by all means, please contact me. I think that's it here. I thought I had a slide that said questions, but I think that's it. I know I said a lot in a small amount of time, so thank you for your time.